This is the story of a unique cancer research organization.
This is an incredible individual and collective experience.
The EORTC, or the European Organization for Research and Treatment of Cancer, is the only organization which makes clinical studies at European level for all cancers.
EORTC is, in a certain way, the reference point for all clinical trials.
The EORTC is an international, non-profit scientific association.
Cancer is a disease that knows no boundaries, it knows no religion, it knows no language, it knows no culture.
The EORTC's ultimate goal is to improve the treatment and therefore the survival and quality of life of all cancer patients.
We always hope that some of the discoveries that will be made will suddenly make that some patients who die will not only survive but will be cured.
The EORTC has made major discoveries and has helped save thousands of human lives.
One of the major early achievements of EORTC is related from the 70s and the 80s. Not many people know that most of patients with cancer were treated aggressively and were dying as a result of infection, like septicemia, for example. And one of the group of EORTC, the EORTC antimicrobial group, developed treatment to better circumvent the susceptibility to infection and to control this septicemia. And one of the real major achievements of EORTC was to decrease the number of cancer patients dying as a result of chemotherapy. And this has been recognized worldwide.
The EORTC has had many great successes in its history. In 50 years, these major advances have radically changed the life expectancy and quality of life of patients. There are many examples of the significant progress made.
There has been one very famous trial in head and neck cancer conducted by the EORTC a long time ago, showing that a much less aggressive surgery could be offered to patients if you add chemotherapy to the treatment, and that was a practice-changing study. So following this important clinical trial, patients no longer had to undergo mutilating surgery.
Think of the larynx, think of the anus, think of the breast. All of these are clinical trials which have actually been carried out by EORTC, shown that organ-sparing treatment can be done, and have massively increased the value of quality of life to cancer patients, not just in Europe, because we're a global organization, but over the whole world.
The EORTC owes these successes and this international recognition to its wide-scale clinical studies, which allow it to develop new and more effective therapeutic strategies.
Human experimentation is essential because although we understand much better now what is wrong on the cellular level, even if we know a gene, if we discover a gene, if we cure a mouse or a rat, we have done strictly nothing for the 1 million patients with cancer every day. And so we have to have this clinical research to really experiment in humans better treatment.
The EORTC's mission is to evaluate the benefit of new treatments as compared to existing standard treatments. Clinical research consists of studying a treatment or combination of treatments on a large number of patients following a strict protocol.
And without these initial critical steps of clinical trials, those progress in the routine treatment of all patients with cancer could not occur.
These trials require hundreds, even thousands of patients, multidisciplinary expertise, and careful control of the entire process, including ethical aspects.
We need large numbers. We need multinational groups. We need an association of people with expertise, dynamism, and capacity to accrue patients into clinical trials.
And interestingly, even pharmaceutical industry is not able to run all the trials that they would like to do, because they don't always have the access to the appropriate patient numbers.
The strength of the EORTC lies in its being able to activate a European network and to bring together quickly thousands of patients to take part in these research programs. This network is comprised of university hospitals and committed clinical staff involved in independent academic research.
It's 2,500 oncologists distributed in 300 university hospitals who want to work together voluntarily to conduct independent clinical research.
This network is, of course, the reason of the EORTC to be, because they raise questions and they get the result, the output of the EORTC for the routine treatment.
But in order to achieve that, they need the second component, which is as critical and which is the EORTC headquarters, which is an infrastructure allowing them to have projects and to conduct their clinical research and their clinical trials on an independent basis.
Independent academic clinical research can be expressed also as investigator-driven clinical trials. In other words, it's a research that doesn't start from industry.
For over 40 years, the Children's Leukemia Group of the EORTC has demonstrated high commitment to this academic, independent research. This group has revolutionized the treatment of leukemia. Leukemia used to be a death sentence for children, but there has been major therapeutic progress since the 1970s. Radiotherapy complemented the therapeutic strategy based on aggressive chemotherapy. The side effects of radiation of the brain were very negative for the future development of children who survived.
The Children Leukemia Group of the EORTC decided to start a new treatment where we made choice to adapt treatment to the risk factors.
In 1983, the EORTC proposed a new, less aggressive treatment without irradiation of the brain. These children will be able to develop normally on the cognitive, physical, and neurological levels. Ilse was the first little girl to benefit from this new treatment.
Ilse was admitted in our hospital in 1983, and at that moment she was 9 years old.
Professor Benoit diagnosed that Ilse had a lymphoblastic leukemia.
Ilse was really the first patient in this trial of the EORTC where we have done this. And we did knew at that moment that if we had avoided radiotherapy, the quality of surviving for this patient was much better.
When I realize now that the fact that I have 3 wonderful children, and the fact that I have been studying, the fact that I'm having a challenging job, actually it's kind of a wonder that all this can happen to me after the treatment.
Today, particularly in children, by continuous trials and errors, we can cure for the lymphoblastic leukemia, we can cure about 80% of the children that will have a completely normal life, something that was unbelievable at the beginning.
So it's very important that those programs are going on and that the treatments are made better and better for the patients in the years to come.
Well, I think it's of major importance that patients participate in clinical trials. We have to realize not only as a medical community but also as a society and as patients that the only way to develop medicine and to improve care for patients and the outcome for patients with cancer is by doing clinical trials.
Clinical trial guarantees you a certain minimal level of quality. There's also quality control. It's not just myself deciding what is right for a specific patient, but it has to be gone through peer review, reflection, and so on.
So it creates a type of
disciplined environment that leads to better care. This is well known. It's one of the effects of doing clinical trials.
Participation to clinical trials is really key for further progress in patient care.
I'm always surprised how many patients are willing to join studies if you propose them to them, if you take the time to explain to them why you want to do a certain experimental treatment, what the reasoning behind it and what the outcome could be.
EORTC trials have never compromised on any rigor in terms of the experiment, in terms of the statistical analysis, in terms of the quality control.
Obviously, such organizations create a momentum of knowledge which benefit every single cancer patient today.
Treating and saving lives are the challenges in this race against time when dealing with cancer.
This quest for major improvement are coming from understanding the mechanisms of life.
Understanding and treating cancer involves going to the very heart of living mechanisms.
It's a disease which affects all cells, and in particular all multicellular organisms, including humans, of course. So it's something which has occurred since the very early ages of biology.
Our body is composed of billions of cells which divide and multiply daily. It is this principle which allows us to replace our cells which die naturally with new cells. This is a controlled phenomenon, but sometimes there is an imbalance.
Cancer is a proliferation of a cell which is unrestricted by normal mechanism of control.
When there is a loss of control, the cancer cells proliferate. The discovery of the structure of DNA in 1953 has made it possible to understand this phenomenon. DNA contains all the information necessary for an organism to function normally. The nucleus of every cell in the body contains DNA. When the cells divide, the DNA also divides in order to transmit the information it contains. DNA comprise our genetic information. When the transcription of some genes is altered, the control of the cell is lost. This causes the cell to be totally out of control, and then it divides in anarchic fashion and does not die.
Cells are dividing, and dividing. And then at one point in time, they will see it in the regional lymph nodes, and then in one point in time, they will see it outside in the body. This is what we call metastasis.
With the localized tumor, the first strategy is surgical intervention. Surgery is aimed at removing the tumor and evaluating its severity and spread. The lymph nodes near the tumor are analyzed immediately. Radiotherapy is often used as a complementary approach to surgery. Radiotherapy consists of attacking the DNA of the cancerous cells with irradiation.
And what we do, by targeting the nucleus of the cells, we cut the DNA into pieces. And because of that, the DNA cannot function any longer the way it should do. And this will lead to cell death.
Chemotherapy is essential when the cancerous cells have metastasized in the body. It is administered by injection or in pill form. It is diffused throughout the body and can attack the local tumor and the metastasis.
Since we had chemotherapy coming, and with chemotherapy there have been a number of diseases which get cured. Then we learned to combine chemo and radiation, and the combination of chemo and radiation was another success story with several examples within EORTC.
But that's not all. There are lots of other treatments for specific cancers, such as hormonal therapy or immunotherapy, for example. It took a long time to achieve this result. It started in the 1960s when clinical research on a large scale was still in its early beginnings. In 1940, the Belgian oncologist Henri Tagnon went to work in Boston, then in the Memorial Sloan Kettering Hospital in New York. 12 years later, he returned to Europe to be involved in organizing the Bordet Institute in Brussels. He worked with a small group of visionaries, like, for example, Silvio Garattini, Georges Maté, and Dirk van Buchem.
We decided to do something, and the first idea it was to establish an European group that at that time was called GECA.
Together they founded the GECA, Groupe Européen de Chimiothérapie Anticancéreuse, in 1962.
They really saw the need and they really had the vision to organize in Europe a structure a little bit similar to what was present already at that time in the US.
We are entering the age of the cure of cancer, just as we were entering the age of the cure of infectious diseases 35 years ago.
We believe at that time that chemotherapy was a new frontier. The idea or the dream at that point was that we should have been able to develop drugs that were more selective, and therefore drugs that were capable to kill only the cancer cells and to spare all the normal cells, and this way to avoid the toxicity.
Together they designed the methodology for clinical trials. With the GECA, they paved the way for the future of European clinical research. In 1968, the United Kingdom joined the GECA. The group then changed its name to become the EORTC.
EORTC, the European Organization for Research on Treatment of Cancer, coordinates resources and talents in 10 European countries.
Cancer treatment depends from different modalities. That's why we name EORTC, European Organization for Research and Treatment of Cancer.
This activity of all European countries together with the same goal to be reached is a tremendous form of cohesion. Science is the leading type of activity to keep together the various countries.
This is a concept. The realization of the concept took 20 years.
We were organized by working group, so there was a working group at the beginning for the screening of new drugs, but there was another working group that was instead interested in the methodology of clinical trials, and there was another group that was thinking more to hypothesis of prevention of cancer.
EORTC was successful mostly because some groups, EORTC groups, were successful. These are groups of friends.
At the start, there was no financial support for these groups. Lack of money was one of the difficulties they faced. The large research institutions in Europe also had to be convinced to work with them and to exchange information.
It was, at this time, it was a revolution. And we had to demonstrate that in every institution, things were not perfect. And that we had to make corrections to make sure that in EORTC trials we were not adding apples and bananas, but only absolutely the same type of patients treated in the same way. And once we made the first publications showing the results and showing the need to develop quality assurance, then it became accepted worldwide.
1972, Brussels, Belgium. The National Cancer Institute set up a liaison office.
EORTC began what was to become a very successful long-term collaboration with the National Cancer Institute.
In 1974, the first European data center was set up with financial support from the American NCI. Headed by Maurice Taquet and assisted by Omar Yodar from the NCI Liaison Office and Henri Tagnon.
We felt that everything was moving when we had the support of the National Cancer Institute of the United States.
Some of the funding that EORTC receives from the NCI, which as it has done historically, is really to help us when there's accrual into NCI clinical trials to be collecting the data in Europe and to curate the data and manage it for us. So that certainly puts much less of a burden for the United States Cooperative Group headquarters, for instance, which would otherwise have to do that in the international sites based through Europe.
On that basis, we will have on both sides of the Atlantic a partnership between two organizations of equal strength, and collaboration, exchange of information will take up a new significance in the fight against cancer.
The EORTC Data Center has a data bank which centralizes the information collected in the EORTC clinical trials. The medical results are then published for the benefit of patients and the entire medical community.
Most important accomplishments, I think, falls into several different areas. One has been really building up the statistics department at the EORTC into an internationally recognized unit.
Today, there are data on over 150,000 patients from around 30 countries. In Brussels, the data is managed by a permanent team of around 170 staff members.
The first thing that has to be done is to clarify what the question is. So, what is the question you clinicians want to see answered? And then, starting from that point, to build a trial that has the capacity to distinguish good or bad luck from systematic tendencies in the data.
The EORTC has come a long way since 1962 and has been very successful. Successive presidents at the head of the board have promoted and developed the original vision.
It's certainly not easy to be a good president, but I think that the role of the president is, first of all, to try to understand how the world is changing, to make sure that an organization like the EORTC can adapt to this rapidly changing world. And as a president, you really have to try to help all the groups in the organization.
In 1990, the EORTC needed extra space and relocated from the Bourdet Institute to more spacious premises in Woluwe, in another part of Brussels. The US NCI Liaison Office also relocated with the EORTC to the new headquarters.
And that new era materialized with the venue of Françoise Meunier in 1991. And from that time on, it was really the development of modern EORTC.
Françoise Meunier was appointed head of the EORTC headquarters and reorganized its structure. From 1991 till today, the EORTC has increased from 28 to 170 staff members from over 14 nationalities.
That was the first time that we had a director who was taking care of all the aspects, not only of the scientific direction, but also on the day-to-day management of a growing team.
All clinical trials must be validated by ethical committees and comply with national and international legislation.
Because of the legal requirement and all the administration that was attached to the conduct of clinical research, we had to adapt the infrastructure and also to be able to face, for example, insurance coverage and all of those processes. And beside that, there was also another challenge, which is a fantastic challenge, was modern oncology and implementing the discovery of basic research, of targeted medicine, of personalized medicine, and the change in the way we conduct clinical trials because we much better understand what is wrong at the cellular level. So at the same time, we have to face legal and administrative challenge, but also fantastic challenge and numerous targets to address in order to develop much better treatment.
The headquarters are the brain of the organization.
The headquarters is composed of different departments specialized in scientific, legal, operational, and training matters. The EORTC is managed by a board and an executive committee which selects the projects to be activated.
EORTC is very keen to promote education and methodology on clinical research. We don't learn clinical research at university during the med school, and it is very important to train the young generation of physicians and statisticians on methodology. That is the reason why EORTC has created a variety of courses on either statistics, for example, for non-statisticians, or one-day introduction, or a very advanced course on methodology. Various courses where you can learn how to do modern clinical research.
Since 1991, the EORTC has a fellowship program allocating grants to welcome medical doctors and statisticians to headquarters to teach them the methodology of clinical research.
This fellowship has been extremely important and very successful. So far, more than 120 fellows have spent at least 1 year, up to 3 years, at the EORTC headquarters.
Alyssa Fairchild is an oncologist specialized in radiotherapy and recipient of the Emmanuel van der Schuren grant, dedicated to quality assurance in radiotherapy.
The Emmanuel van der Schuren Fellowship was established in 2001, who was really a visionary radiation oncologist in Europe. I was trained and I was actually in practice in Canada before I came here to go back to school at EORTC. And there really isn't any other opportunity anywhere else in the world that I know of that offers this type of training in quality assurance specifically for large international clinical trials. It was an honor and a privilege to come here and learn about how those trials and future trials have been established and conducted.
It's amazing the amount of work that has been done by all these fellows.
And so actually what I was doing this morning was writing a letter to my boss at home to try to brainstorm some ideas of how we can continue to collaborate with EORTC.
EORTC is extremely grateful to various National Cancer League and also in Belgium to Fonds Cancer, the FOCA, which was created by Professor Tagnon, who helped us to create those fellowship programs and to fund those fellowship programs.
In 1993, the EORTC set up a Quality of Life department with funding from the European Commission. The department supports the research done by the Quality of Life group. The objective is to evaluate the importance of the different factors influencing the quality of life of patients. This department encourages doctors to pay great attention to subjective data, such as suffering, isolation, sexuality, fatigue, and other symptoms.
But more than 15,000 patients have entered into our clinical trials. So we now have numerous studies where we can say whether the side effects of the treatment. So for me, it's a real innovation that we can now not just look at the survival and the clinical endpoints and the hard endpoints, but look at what we often call the soft endpoints, but endpoints that really matter to patients.
You can imagine the phenomenal difficulty of measuring this cross-culturally in Europe. Well, the EORTC has developed tools which allow you to do this, and without which the evaluation of benefits and risks of drug would be very difficult.
The Quality of Life department also campaigns to European bodies to inform the political world of the central importance of the patient.
For me, the future challenges and innovations that we have to make are really about making policymakers aware of the challenges that we face in terms of quality of life in clinical trials. And that's why we recently ran a conference at the European Parliament to talk about this. We will be continuing this dialogue and have additional support now from the European Parliament to continue this to 2013 and 2014. So I think discussing with policymakers, discussing with patients, getting them all to interact together are quite key points in terms of taking quality life forward.
All Although the EORTC is evolving, its role and mission remain unchanged. The independent evaluation of new strategies or innovative molecules being developed by the pharmaceutical industry. The EORTC encourages fruitful collaboration and partnership between researchers, clinicians, patient advocacy groups, cancer leagues, and the industry.
You cannot take drugs in isolation and then say, well, now it's approved and now we know what to do with it. It's far from that. It will generate many more precision questions as to how to best use new therapeutic strategies. And this is, of course, not only true for new drugs, it's also true for new radiotherapy techniques, it's true for new surgical procedures, it's true for new diagnostic and imaging procedures, and it's true for the whole continuum that composes the correct approach to tackling the cancer problem.
There is an increased economical pressure also for industry. There is an increasing requirement, very well justified from the patient to have access to a new drug more rapidly. And I believe that all these parameters put together must force the scientific community, academia and industry to work together along new lines of cooperation.
The EORTC initiates also external partnerships with national groups, especially for rare tumors which require a large number of patients. The EORTC has been particularly successful in activating research on these rare tumors throughout Europe.
The EORTC is the #1 organization in Europe to conduct clinical trials for some rare cancers. So the track record of the EORTC in conducting trials in brain tumors, for example, in melanoma and sarcoma is truly outstanding.
This is also the case with gastrointestinal stromal tumors, GIST, which are considered to be rare or orphan diseases. In the year 2000, Luc was diagnosed with GIST. This young father's world collapsed around him. His chances of survival were virtually nil.
At that time, we already knew that the only way to treat this disease efficiently was surgery.
The operation happened in emergency by one of the professors, oncologists. And the operation was successful. And I had to come every 2 weeks, every month back for a scan and to have a checkup. And for months, everything was fine. And suddenly, that happened in October of 2000, they saw again a very spectacular tumor, almost of a fist large.
And he immediately relapsed after the first surgical treatment.
I was really shocked because nobody expected that, and there was no indication. You don't see clear anymore. Yeah, there's no panic, but everybody is well aware of the possibility that everything could have passed life could end very, very soon.
A major discovery was made at the same time. In the laboratory, GIST was suspected to react positively to a new molecule, imatinib, more well known today under the name Glivec.
The new drug was available only in the context of clinical studies on both sides of the Atlantic. And a major part of the early development of this compound in this tumor type was done in Europe through the EORTC.
And this was new, so they said, okay, we don't know exactly what will be the second effects, yeah, but it's you take it with pills and it's a trial, but we think, and the small information we have, we think that's okay, and the hope passes also through us. Yeah, we said, okay, let's do this. This is just like an aspirin. You don't feel so bad, although there was a lot of second effects.
This new molecule has been tested successfully for a certain type of leukemia. Researchers then put forward the hypothesis that it could also be active for GIST, a too rare tumor to be interesting for industry investment. The EORTC then decided to fund clinical research into this new treatment.
By chance, he lived nearby an institution with very active involvement in EORTC activities, and by chance our institution had activated the right trial for the right patient at the right time.
And I remember asking the professor, and what is the alternative? He said, okay, we have an operation every 6 months and we put a zipper. So that was the alternative.
Professor van Oosterom immediately proposed to Luc that he should take part in these clinical trials. Luc accepted.
And immediately there was a result. There was a necrosis, immediately necrosis of the tumor. The tumor shrinked a little bit. We had the impression, and it was like that we had to explain what we felt. They put it in a database, and they helped other persons with that. So it was instead of getting information, we were giving information about what we feel, what we felt, what were the second effects, and so on. So it was very interesting, and we were a little bit proud also that we could help in that way.
He helped us, among hundreds of other patients, to understand how the drug works, which patients will benefit the most from it, and how we can deal with the potential adverse events, the side effects of the treatment.
The treatment saved Luc, but did not cure him. The purpose of this targeted treatment is to control the cancer and to prevent it from spreading. Luc's disease has been stable for over 10 years. The study showed that mortality was 90% before Glivec, and that there was a radical increase in the survival rate with Glivec. Luc's cancer has become chronic. For over 10 years, he has had to make regular visits to his doctor to check his condition.
In case there are any problems in the
We are very lucky that we are 11 years later, and we are still there.
And that's a major change that has happened in oncology since 2000 roughly, because for several tumor types we are now using this type of targeted approaches which help us to transform cancer from an acute life-threatening condition to a more chronic condition.
We have better molecular understanding of the disease, and based on this can have very selective, targeted, smart treatments. And that's what we're working on right now. So individualizing patient care, but still have this on a solid scientific rationale and basis.
Today, 55% of cancer patients are cured, and further major progress can be expected based on what we now know. Enormous hope is being placed in these new types of targeted treatments. New opportunities are opening up before us. Scientists are moving forward with enthusiasm but also with caution, as it takes years to fully exploit the anticipated potential. In partnership with the US NCI, ASCO and AACR, the EORTC organizes high-level scientific meetings on molecular markers and molecular targets.
To paraphrase a very famous oncologist, he said, sometimes it is simply different diseases hitting the same organ. So you cannot say it is anymore breast cancer. It is different diseases hitting the same organ. We have to very much go back to the basics first. Really try and measure in a very undefined way everything that is going on in the tumor, try and understand as well as possible, then reduce that information to something we can translate and use in the daily practice in the clinic. But so it's really at the basis that is the gap of our knowledge is over there.
Clinical research today is no longer separate from basic research. The link between the laboratory, the hospital, and the patient is called translational research.
And if we look at major publications right now in the field of oncology, everybody knows that translational research is what we should all do.
At the EORTC, we strongly believe that translational research is really the key for further progress and improvement of cancer. And we think that it's very important to individualize cancer treatment more, and by looking for prognostic markers, predictive markers, and also tools to early assess whether or not the treatment is active. That's the best way to go forward in this field.
The purpose of the EORTC imaging group is to develop the scientific and clinical value of state-of-the-art imaging and to standardize its use in its clinical trials conducted by the EORTC. Data from imaging has the potential of providing information previously unavailable. making it possible to better understand the disease, its diagnosis, its prognosis, and to select the best therapy and the best way to monitor the response to the treatment.
I think the benefit for the patients after the trial is done is that hopefully you have an imaging biomarker, so you have a measurement on an imaging modality where you can say on an early stage that the treatment is working or not. So now often you have to give a treatment for weeks or months before you know that it's working. We hope with these new imaging modalities that maybe you can already see it after 2 weeks.
Winning time is a major challenge for medicine, facing new measurement tools or technologies to make it possible to quickly adapt the treatment to each patient.
The biggest success is that now we have science-driven medicine, whereas what we were doing 50 years ago, well, it was very much just observational.
And this has had a major impact actually on the way EORTC today conducts a clinical trial and also the infrastructure that EORTC headquarters provide to its network to achieve such trials that are really bringing us many, many new challenges.
The horizons of science have suddenly become so wide that we must expect new tools. Biobanking will play an essential role in the near future in how clinical trials are conducted.
Today, we try to collect the tumors of all the patients in clinical trials. We try to collect blood from these patients, and then we analyze this very precious material using the best technologies available, and we try to understand why some patients do so well and why some patients are not at all responding to the treatments.
We need to prospectively collect biological material in a very structured manner and according to very high quality standards.
I think this is a phenomenal effort that where again EORTC is paving the way, and we wish them all the success.
With translational research and biobanking comes the need for a new harmonized legislation.
The general will of the European Parliament and the Council was to develop a legislative framework that then can be implemented at the national level. While the general frameworks had been put into place, it had been adapted to the national legislation, and sometimes it has not been adapted in a uniform way, which creates for the investigators involved in clinical trials some difficulties.
It's absolutely clear that the bureaucracy involved in clinical research today is a lot worse than it was when I started 30 years ago. But the EORTC has been very active in trying to reduce this bureaucracy.
EORTC, as an academic organization, has played a major role in voicing these challenges and these obstacles.
We are now at the moment when all this input is analyzed, and a proposal for the new directive is going to be put forward shortly. Obviously, that after the proposal is put forward, it will have to go through the European Parliament, through the Council, and ultimately it has to be uptaken by the national authorities.
We still have to wait to make sure all the suggestions will be translated into a more efficient and easy international network.
The EORTC must mobilize resources to pursue its mission both at national and European levels.
Through the eyes of the Americans, EORTC is pretty much a miracle when you look at the budgets and what has been achieved with what kind of money.
We need to be tackling the issues of cancer care in Europe urgently, because we've not just got to deal with the patients who are around now, but this enormous wave of cancer patients who are coming in the next 20 years because people are living longer. So there was never a time that EORTC was more needed than now. And there was never a time when EORTC needed independent money, independent of pharma companies, independent of tags and commerciality.
In 1976, the EORTC set up a charitable trust to finance EORTC activities. Its honorary president today is Her Royal Highness Princess Astrid of Belgium, who succeeded His Royal Highness Prince Philip, the Duke of Edinburgh, Her Royal Highness Queen Sophia of Spain, and Her Royal Highness Queen Sylvia of Sweden.
The Charitable Trust of the EORTC is a tiny organization which works very hard to raise money for cancer research, research to produce better treatments for cancer by EORTC. And we are always trying to find new ways of raising money.
With very modest financial support, the EORTC has already shown that it can make a significant contribution to the treatment of cancer. With adequate and assured resources, European cancer specialists will be able to mobilize and coordinate more talent and wider experience for the campaign to improve the treatment of all forms of the disease, which leaves few families untouched.
As the honorary president of the EORTC Charitable Trust, I am pleased to be able to participate in the activities of the Trust to support the EORTC and its fight against cancer. Together with my predecessors, Her Majesty Queen Sylvia of Sweden, Her Majesty Queen Sophia of Spain, and His Royal Highness Prince Philip, the Duke of Edinburgh, we have taken on this important responsibility with one goal in mind: to improve the treatment, quality of life and survival of cancer patients. In these difficult financial times, where budgets are often cut, the support provided by the Trust will allow the EORTC to continue to carry out academic clinical trials, testing new treatment strategies which answer questions of direct importance to cancer patients. It is vital that such research activities continue if we are to meet our goal of improving the treatment of cancer. We are all in this fight together, and I find it personally rewarding to play a part in the activities of the Charitable Trust, in the support of the EORTC and its goals.
EORTC was created as a result of a dream or a vision. It brought in Europe international cooperation and multidisciplinarity. It is today a reality. But we need to go further. It is a necessity for the future patient with cancer, and if we want to bring them further progress, we really have to bring to all the partners involved, the staff and the network, and the patient and all the supporters, the fantastic energy of hope.
The EORTC is grateful to the EORTC Charitable Trust, the Fonds Cancer, FOCA, and all the cancer leagues. The U.S. Cancer Institute, the Belgian Lottery, and the Belgian Science Policy Office. Its partners from the pharmaceutical industries, and the following EORTC suppliers for their donations. With the support of the Minister-President of the Government, the Minister of Scientific Research, and the Minister of Exterior Relations of the Brussels capital.